Hello everyone. Greetings for the day. Myself, Dr. Divesh Arora, presently working as the head of the department at Asian Hospital, Faridabad. I'll be taking you through the gastric ultrasound as a point of care ultrasound examination. These are my set of disclosures. My conflict of interests are nil for this set of lecture. You'll be seeing a lot of images which are from Google and the references are from PubMed. And I wish to mention that I am a great ultrasound guided regional anesthesia as well as POCUS enthusiast. So these are my learning objectives for this lecture. First, we'll try to understand what is gastric ultrasound. Next, we will understand that why do we need to do gastric ultrasound, and then how do we actually do it in our day-to-day practice. Let's begin with a brief introduction about gastric POCUS. It's a simple, a fast, bedside non-invasive test which is quite accurate, reliable as well as a diagnostic test. It is generally done as an objective assessment for gastric contents, and it is both qualitative, my dear friends, as well as quantitative. Now, the reason which we do this ultrasound as a bedside test is because of the fear of aspiration of gastric contents. As anesthetist, intensive care physician, as well as ER physician, whenever we see aspiration of gastric contents while securing airway, we have a risk of hypoxia, bronchospasm, pneumonia, and if not settled down, it will lead to ARDS and can lead to death. And as anesthesiologist or as any other physician, we would not like our patient to have all these morbidities and mortality. So let's look at a paper which was published as early as 2000 and which showed that the risk of perioperative aspiration is around 0.8%. And if it actually happens, it leads to a fourfold increased risk of intensive care admission. And the length of stay increases by 9 days. And the in-hospital mortality, my dear friends, increases 7.6-fold. And added to all this is a big cost of around $19,000 to $25,000. And this is a huge impact. So are there any risk factors which can help us in predicting the aspiration risk? Yes, as per the study which I quoted, male sex, non-white race, elderly people are more prone to have aspiration. Patients who have delayed gastric emptying, particularly the patients who are having a renal disease, COPD, who are demented, are having malignancy or moderate to severe liver disease, as well as ER emergency room admission, are particularly at risk for aspiration of gastric contents. So the big question comes to our mind is, whenever we are securing an airway, can we reduce the aspiration risk? The answer is yes. We can certainly reduce the aspiration risk. The next question which comes to our mind is, how do we actually reduce the risk? The biggest risk reduction is possible if we actually follow the fasting guidelines which have been given by the American Society of Anesthetists, and frequently it is updated, and now our Indian Society of Anesthetists has also come up with the guidelines according to the Indian context. So these guidelines clearly mention that we need to fast for 2 hours for clear liquids, which includes clear water, 4 hours for a human breast milk, 6 hours for non-human breast milk, infant formula or light meals, and if the individual has had a fried fatty meal containing non-vegetarian food, it's 8 hours. So in spite of following these guidelines, we do not have clear set of guidelines available for patients with delayed gastric emptying, by which I mean patients with diabetic neuropathy, who are having renal disease, uremia, gastroesophageal reflux disorder patients, obese, and the patients who are using chronically opioids. So although we may be following these guidelines, but it's not foolproof that aspiration will not occur. So in order to understand gastric ultrasound as a point of care ultrasound examination, we need to follow the IAIM framework, which was given by David Brenner and colleagues and published in Journal of Ultrasound in Medicine in 2012. And it's an acronym which stands for I, that is the indication of the POCUS, whether the patient is actually fasting or not, then how do we actually acquire the image and optimize and correctly interpret and take an adequate decision. Now let's try to understand various indications of gastric ultrasound. first and foremost is the fasting status is either unreliable or unclear. When can it actually happen? In individuals with altered sensorium, these days we are having a lot of international patients and there is certainly a language barrier, and in these set of patients we can have an unreliable fasting status. And patients who are elderly, who are demented, having some sort of delirium, and pediatric patients, generally pediatric patients, they will be staying with their grandparents or parents in the night and somebody else would be bringing them to the hospital. So at times the history may not be reliable, and certainly in trauma patients the history cannot be reliable, particularly under the influence of alcohol. So another set of indication is the delayed gastric emptying. This particularly happens in a patients who are actually in labor, who are having diabetic mellitus neuropathy, and patients who have been taking GLP-1 agonist for weight loss as well as diabetes mellitus. In patients who are having uremia or liver dysfunction, gastric emptying is delayed. Particularly patients with neuromuscular disorders, critical illness, and severe obesity can also have delayed gastric emptying. Another important indication is there is a lack of adherence to fasting instruction. This can particularly happen if there is an emergency surgery, or there is an urgent procedure, or there is some kind of miscommunication. If you have clearly communicated that it should have been 2 hours for clear liquids, but patient did not listen to you. Now, how do we actually acquire the image? So first of all, we need to select the transducer. The transducer which we need to select is the curvilinear transducer, which will hold good for adult population as well as pediatric population greater than 40 kgs. If we are having a pediatric population which is less than 40 kgs, then we can go for linear transducer because stomach is quite superficial. And we have to choose the appropriate preset, that is abdominal, and the orientation indicator has to be directed towards the head of the patient or cranially. Next important aspect is how do we actually position the patient. As you can see in this figure, the patient is supine, as well as we have to do this examination in right lateral decubitus. So we turn the patient into RLD position. So we have to understand one important thing is that supine position alone can rule in, but it cannot rule out a full stomach. So in order to have a complete examination, you have to do first in supine and then in right lateral decubitus position. Where does the anesthesiologist stand? For all POCUS examination, anesthesiologist generally stands on the right side of the patient and generally has the machine on the same side, so that with the non-dominant hand we can manipulate the ultrasound controls and save the images and as clips whenever it is required.